The cardiovascular system is composed of the heart and the blood vessels. This is a system that circulates blood throughout the body so that oxygen and carbon dioxide can be exchanged with the tissues, nutrients can be delivered to the tissues, and waste products can be brought away from the tissues. The heart weighs about 250 to 300 grams and is roughly the size of your fist. It's located in the mediastinum. This is a collection of tissues between your lungs. One side of the heart rests on the diaphragm. This is the muscle that separates your thoracic cavity from your abdominal cavity. It does lie a little bit more to the left of midline, about 2/3 to the left of midline. The broad part, known as the base, points toward your right shoulder, and the apex or tip of the heart points toward the left hip. So as we see, right down the middle here is the midsternal line. You can see the heart is more on the left side than the right. Here is the diaphragm, and the heart is laying on the diaphragm. This is called the base of the heart, and it is pointing toward the right shoulder. And here the apex or the tip is pointed toward the left hip. The heart is surrounded by the pericardium. This is the outer covering of the heart. There is a fibrous pericardium, which is a tough bag that surrounds the heart. This tough bag is lined by a serous pericardium. You'll remember that serous membranes line cavities with no natural openings to the outside. The part of the serous pericardium that lines the fibrous pericardium is known as the parietal layer. It folds back and covers the heart, and this is the visceral layer. Serous membranes secrete serous fluid, in this case pericardial fluid. This acts as a lubricant between the layers. As the heart beats inside the pericardial sac, it allows for a friction-free environment. So the pericardium is sort of like a ball or a balloon that you can push your fist into. Your fist would be the heart. So we have the outer wall, and then we have the inner wall. So the outermost wall is that fibrous pericardium, and it will be lined by the parietal pericardium, which will fold back and cover the heart as the visceral pericardium. In the pericardial space is where we will have the pericardial fluid. There are 3 layers to the heart. The epicardium is actually the visceral layer of the pericardium. This is a single layer of epithelial cells. The myocardium is the muscle layer. The muscle cells are held together by fibrous connective tissue. The myocardium is the largest part of the heart. The endocardium lines the inside of the heart. This is a smooth endothelium. It is only 1 cell layer thick. Its function is to make the inside of the heart nice and smooth. So as we look up here where we have the pericardium attached, we have the fibrous pericardium, and then here is the serous membrane pericardium, the parietal layer. It folds back and covers the heart as the visceral layer of the pericardium or the epicardium. They're the same thing. The muscular wall is the myocardium, and then the single lining of cells makes up the endocardium, and this would be the inside chamber of the heart. The heart is composed of 4 chambers, 2 atria, that's a plural, singular is atrium, one on the right side and one on the left. The atria are known as the receiving chambers. When blood enters the heart, it comes into the atria. Then there are 2 ventricles. Again, we have one on the right side and one on the left side. These are the discharging chambers of the heart. Blood leaves the heart from these 2 chambers. So as we look at the heart, we have the right atrium and the left atrium, and then we have the right ventricle and the left ventricle. Since blood enters and leaves the heart, we have to have 4 major blood vessels associated with the heart. The right atrium has the inferior and superior vena cava attached to it. Blood will return from the body to the right atrium through these 2 blood vessels. The left atrium has the pulmonary veins attached to it. There are actually 4 of these. This brings blood back from the lungs. The right ventricle has the pulmonary trunk or the pulmonary artery associated with it, and the left ventricle has the aorta attached to it. So as we look at the blood vessels, the superior vena cava and the inferior vena cava return blood to the right atrium. This will drain blood from the upper part of the body. This drains blood from the lower part of the body. The right ventricle is attached to the pulmonary trunk, which branches immediately into the right and left pulmonary arteries. So this is an artery. The pulmonary veins, and there are 4 of them, all converge in the back of the left atrium. They return blood to the heart from the lungs. The left ventricle is attached to the aorta. The aorta will distribute blood throughout the entire body. There are also 4 valves in the heart. The atrioventricular valves, or the AV valves, are between the atria and the ventricles. So we have the right AV valve, sometimes called the tricuspid valve, and the left AV valve, sometimes called the bicuspid valve. Then we have the semilunar valves. These are between the ventricles and their associated blood vessels. So on the right side, we have the pulmonary semilunar valve, and on the left side, we have the aortic semilunar valve. So here we see on the right side, the right AV valve, or the tricuspid valve between the right atrium and the right ventricle. Here is the left AV valve, or the bicuspid valve, also sometimes called the mitral valve, and this is between the left atrium and the left ventricle. The pulmonary semilunar valve is between the right ventricle and the pulmonary trunk, and the aortic semilunar valve is between the left ventricle and the opening to the aorta. The aorta is under here and comes up out this way. The purpose of the valves in the heart is to prevent backflow. When the heart contracts, it's going to squish blood in both directions, a lot like squeezing on a ketchup container. Ketchup goes to both ends of the little container. We don't want that to happen. We want blood to only move in one direction, and the valves help us maintain one direction flow. The chordae tendineae are special little cords that are attached to the valves and attached to muscles in the wall of the heart. So this helps control how far closed the valves will go. Whenever the heart contracts and blood tries to flow backwards in the heart, the valves close like little one-way doors. The chordae tendineae don't let them go too far the other direction, and this prevents blood from flowing backwards in the heart. If the valves don't work correctly, we say we have incompetent valves, that will give rise to heart murmurs. With a heart murmur, what you're hearing is blood bubbling back through the heart valve in the wrong direction. Valvular stenosis is something that can happen with aging. These heart valves are supposed to be nice and flexible and elastic, and as you age, your elastic tissues tend to become hardened and less elastic. If this happens in the valves of the heart, they may not close completely. So older people sometimes have mild heart murmurs as a result of valvular stenosis. Let's look at how blood flows through the heart. We always return blood to the heart through the inferior and the superior vena cava, and that empties blood into the right atrium. When the right atrium contracts, blood will be forced through the tricuspid valve into the right ventricle. When the right ventricle contracts, the blood will be forced through the pulmonary semilunar valve into the pulmonary trunk, which will branch to the right and left pulmonary arteries. The pulmonary arteries will take blood to the lungs so that the blood can pick up oxygen. The pulmonary veins return blood from the lungs to the left atrium. When the left atrium contracts, blood is forced through the bicuspid valve, or the mitral valve, into the left ventricle. When the left ventricle contracts, it will force blood through the aortic semilunar valve. Blood will then flow into the aorta, and the aorta will branch repeatedly to send blood to all of the arteries of the body. The arteries of the body will branch to capillaries. The capillaries will deliver oxygen and nutrients to all of the tissues. Carbon dioxide will be picked up. The capillaries will fuse back to become the veins of the body, which will all merge to eventually become the inferior or superior vena cava, which will return blood back to the right atrium. The heart itself requires constant blood supply. This is called the coronary circulation. Coming directly off of the aorta, right at the base of the aorta where it first comes out of the heart, we have the right and left coronary arteries. These will branch and blood will flow to the capillary beds of the cardiac muscle. As the gas exchange occurs in the cardiac muscle, the blood will be collected by the cardiac veins, which will return the blood to the right atrium. Angina pectoris is a condition that occurs when there is reduced blood flow in the coronary arteries. This may be the result of blockage of the coronary arteries temporarily or spasms that narrow them down considerably. Because the myocardium doesn't get enough blood, the muscle cells begin to die a little bit. This is called ischemia. Typically, people who have angina pectoris have a prescription for a vasodilator. This will help open up the blood vessels. If they don't take their vasodilator when they first feel the chest pain, then the spasming may continue and lead to a myocardial infarction or an MI. This is what happens when there is a prolonged blockage of the coronary arteries. Here, the cells actually die. Because cardiac muscle cells are incapable of cell division, this tissue will not repair. Instead, we will get fibrous connective tissue in its place, and this tissue will be non-functional. This means that when the heart dies, it loses some of its pumping strength. The heart contracts without us thinking about it. This is because of the cardiac conduction system. Some of the cardiac muscle cells are what we call autorhythmic. That is, they can depolarize without being told to. One group of these cells is known as the sinoatrial node or the SA node. Then we have another cluster called the atrioventricular node or the AV node. We have the atrioventricular bundle or the AV bundle or the bundle of His. All of those are the same thing. And then the bundle branches. We'll have a right bundle branch and a left bundle branch. These will lead to the Purkinje fibers, which will go across all of the ventricles. The SA node is one cluster of those autorhythmic cells. When they depolarize, they tell the atria to contract. Now, all of the cardiac muscles are connected to each other by gap junctions. So when we have one group of cells depolarize, all of the cells depolarize. There is a band of connective tissue between the atria and the ventricles that acts as an insulator. So the atria can be told to contract, but the ventricular muscles won't get that message. When the SA node fires and it causes the atrial muscles to contract, it also stimulates the AV node. The AV node will take the signal through that connective tissue band to tell the ventricles to contract. So the AV node will be stimulated by the SA node. This will cause the stimulus to go down the AV bundle. We'll get the right and left bundle branches so we can go to the right and left side of the heart. And these will branch out across the ventricles as the Purkinje fibers. When the message gets to the Purkinje fibers, all of the ventricular muscles will contract. It's important that the muscles of the heart work as a unit. We want all of the atrial cells contracting at one time and then all of the ventricular cells contracting at one time. The SA node is referred to as the pacemaker of the heart. It typically fires about 75 times per minute. So when someone has a heart rate in the neighborhood of 75 times per minute, we say they are in normal sinus rhythm. The AV node is also autorhythmic, but it fires less frequently than the SA node. It will only fire about 50 times per minute. The AV bundle and the bundle branches are also autorhythmic, but they only fire about 30 times per minute. Whoever is fastest controls the heart rate. Whenever the SA node fires and triggers the AV node to fire, the AV node has to start building up to fire again. If the SA node becomes damaged, then the AV node will take over. At this point, the heart will beat about 50 times per minute. Now, the heart beating 50 times per minute will keep blood circulating, but it will not allow the heart to meet very high demands. Sometimes people who have a damaged SA node, if they're sitting around, they're fine, but as soon as they stand up, they get lightheaded. Now, if the AV node goes, the SA node is not working and the AV node is not working, the AV bundle and the bundle branches will still have the heart beating about 30 times per minute. However, this is not fast enough to maintain circulation. The cardiac cycle is one complete heartbeat. Systole is used whenever the heart is in contraction or the heart muscle is depolarized. Diastole is used when the heart muscle is in relaxation or is repolarized. So one complete heartbeat is atrial systole followed by atrial diastole, then ventricular systole followed by ventricular diastole. Or the atria contract and relax, the ventricles contract and relax. Electrocardiography, the ECG or the EKG, can monitor the electrical currents that are generated and transmitted through the heart. When we do this, we get 3 deflection waves. The size, duration, and timing of these waves are very consistent in a healthy heart. If they change, it can indicate that there is a problem with the conduction system of the heart. As we look at an EKG tracing, we have the P wave, the QRS complex, and the T wave. We can also break down into certain intervals and segments, but we're only interested in the waves right now. The P wave reflects the electrical disturbance in the heart when the atria contract. This is when the SA node is doing its thing. As the atria relax, we normally would see a little bit of a wave here because that relaxation has a little bit of an electrical disturbance. But because the ventricles start contracting just as the atria are relaxing, the electrical disturbance of the ventricles contracting, this QRS complex, covers that up. And then the ventricles relax. And there is the little disturbance from the relaxation of the ventricles. So we see the atria contracting, we see the ventricles contracting, and then we see the ventricles relaxing. The atria do relax, but it's in here and it's covered up by the ventricular contraction phase. Here we have a couple of EKG tracings. This top one is a normal sinus rhythm. We see PQRST, PQRST going along very normally and at a pretty consistent rate. This one looks a little unusual. Something is missing. Here we don't have a P wave. We have the QRS and the T wave, but then no P wave. Since the P wave represents the sinoatrial node doing its thing, this means that the sinoatrial node is not functioning. Notice how much time it is from peak to peak here, how many squares pass, as opposed to here. This paper runs through the machine at a constant rate, so you can use this to tell heart rate. So here the heart is about 75 beats per minute. Here it's about 50 beats per minute. This indicates that with no P wave, the SA node is not functional, and the AV node is pacing the heart. So we see only the ventricular contraction and relaxation, and we see a longer time between beats. As we start the cardiac cycle, the heart is totally relaxed. This is called the period of ventricular filling. Blood flows into the atria from either the vena cava on the right side or the pulmonary veins on the left side, and the AV valves are open. The semilunar valves are closed, so blood can simply flow straight through the atria, through the AV valves, and into the ventricles. About 80% of the blood flowing into the atria do this. They just go straight into the ventricles. The AV valves are open at this point, the semilunar valves are closed, so the blood will pool in the ventricles. When the atria do contract, the last little bit of blood in the atria is pumped into the ventricles. Then we start ventricular systole. As the ventricles begin to contract, they increase the pressure in the ventricles. This is going to close those AV valves. Blood will start to try to flow backwards into the atria, and those AV valves will close to prevent that backflow. As the ventricles continue to contract, the pressure in the ventricles will increase and will eventually exceed the pressure in the attached arteries, forcing the semilunar valves open. When this happens, blood is forced into the arteries. On the right side, it will be forced into the pulmonary trunk. On the left side, it will be forced into the aorta. The atria are relaxed during all of this time and are starting to fill with blood, but that blood is not going into the ventricles because at this point the AV valves are closed. As the ventricles relax, we go into ventricular diastole. The ventricular pressure begins to drop. Blood in the arteries want to now backflow into the heart. This is when the semilunar valves close to prevent that from happening. For just a brief moment, the semilunar valves are closed and the AV valves are closed. But then as pressure continues to decrease in the ventricles, the AV valves fall open and that blood that has been pooling in the atria go ahead and start coming into the ventricles. And we start all over again. When you listen to the heart, you hear heart sounds. These are lubbed up. That's actually their name. What you're hearing are the valves in the heart closing. The lub portion, the first sound, are the AV valves closing, and the dup are the semilunar valves closing. The valves are positioned in the heart, and doctors will move the stethoscope around to hear different valves because as they're in different places on the chest, they can hear different valves more clearly. So if they think there's a murmur, they can try to pinpoint which valve it is in. Because the heart lies just a little bit to the right of the sternum, just to the right of the sternum, there are two listening points, one in the second intercostal space and one in the fifth. And then to the left of the sternum, you listen again in the second intercostal space and the fifth intercostal space. In this spot, you hear the aortic valve most clearly. Over here, the pulmonary valve most clearly. This is where you hear the tricuspid valve, and here is where you hear the bicuspid or mitral valve the most clearly. Cardiac output is the amount of blood pumped by each ventricle in 1 minute. To calculate this, you need to know the heart rate and the stroke volume. If you multiply those two together, that is the cardiac output. The stroke volume is the amount of blood ejected from the ventricle with each heartbeat. In a normal heart, this is approximately 70 milliliters of blood. Heart rate is your pulse rate. For a normal heart, somewhere in the neighborhood of 75 beats per minute. If we use these numbers to calculate cardiac output, a normal cardiac output is just a little over 5 liters. You will remember that we have 5 to 6 liters of blood in our body, so you are pumping your entire blood volume every minute. There are some heart rate irregularities. Tachycardia is when you have an increased heart rate. This is when the heart rate is greater than 100 beats per minute when you are resting. You're not doing anything, you're just sitting around. The problem when the heart goes over 100 beats per minute is the heart is beating so fast it may get out of rhythm, and that is called fibrillation. Bradycardia is when you have a decreased heart rate. Here the heart rate is less than 60 beats per minute when you're resting. Again, you're just sitting around not doing anything. Rates below 60 beats per minute may indicate that the AV node is in charge of the heart rate rather than the SA node. Well-trained athletes may have very low heart rates. If they're a well-trained athlete, their heartbeat is so strong that they eject more blood in their stroke volume. If they do that to maintain their cardiac output, the heart can beat fewer times. Congestive heart failure is a condition that occurs when the myocardium has been weakened. This causes a decrease in pumping efficiency. When this happens, circulation cannot be maintained. There are several causes for congestive heart failure. One is coronary atherosclerosis. This is when the blood vessels are not open enough to allow blood to flow to the heart muscle, so the heart muscle experiences hypoxia or low oxygen levels. Hypertension can overwork your ventricles. Repeated myocardial infarctions leave you with a lot of scar tissue on your heart instead of functional heart muscle. And then there is something called dilated cardiomyopathy, DCM. We don't really know what causes this, but for some reason the muscle just becomes flabby. Possibly this is because of drug toxicity, because we do see this in people who are alcoholics or have had excessive cocaine abuse, or it may be the result of a chronic infection. This usually strikes relatively young people. The first three are more problems with older people. When the heart fails, you have to remember that the heart is a double pump, and each side can fail independently. When the left side fails, we're going to have pulmonary congestion. The left side of the heart pumps to the body. If the left side is not pumping to the body effectively, blood kind of backs up into the pulmonary circulation. As a result, fluid leaks out of the blood into the lungs, and suffocation can occur. If the right side fails, then we have what's called peripheral congestion. Now the blood coming back to the heart from the body kind of gets backed up. When that blood doesn't move fast enough, then we get edema out in the body. Usually failure of one side stresses the other side and eventually the whole heart fails.